in the nation pop-up vaccination clinic. As Shah told the Seattle Times, quote, "It's an equity thing. People don't have technology. People don't have the time. It's essentially privileged people that are signing up for these appointments, and the most impacted folks are not able to do it," unquote. The clinic, PICA, helped set up, kept things intentionally low-tech to help prioritize reaching vulnerable seniors. We need to continue seeking out community partners like that to make sure we are understanding the challenges they face and working through them together. Because this pandemic will not truly be over for anyone until we can vaccinate everyone we can. And even when it ends, we need to make sure nothing like this ever happens again. So I'll be saying more about how we do that later this week when I reintroduce the Public Health Infrastructure Saves Lives Act. It was hard to imagine when this pandemic began a year ago where we would be today. But the question before us in this moment is, how soon will students be back in the classrooms? How soon will those people not already at work be back? How soon will we be able to visit safely our friends and family for special occasions and greet them with smiles and handshakes and hugs? We all want to get there as soon as possible, but that starts with the work all of our witnesses are here today to discuss and the steps we take right now to support it. I look forward to hearing from our witnesses about how we end this pandemic and working with them to get all of our communities there. As Ranking Member Burr and I have been talking about since early in January, COVID-19 has defined this committee's work over the last year, and in many ways will define it over the next 2 years. For all of my committee members, hearings like this are just a beginning of our effort to look comprehensively at the impact of the pandemic we are in the middle of. I look forward to working with Ranking Member Burr and every member of this committee as we continue those efforts and work to respond to the COVID-19 pandemic and its aftermath. Keys to this work will also be helping American workers and families recover from all impacts of the virus and the dire economic situation they face, addressing the devastating impacts of learning loss so many children are facing, and the symptoms long haulers continue to fight, and ensuring this country responds to all the ways this pandemic will stay with us for a long time, as well as all the things we should be doing to prepare for pandemics in the future. I know every single member of this committee, no matter how different our politics or our states, is unified in feeling the deep loss caused by this crisis, deep gratitude to all of those on the front lines who are fighting it, and the importance of responding to this moment by building a stronger, fairer, better nation for the people we represent. I look forward to this hearing and working with all of you in the days and months ahead. With that, I will turn it over to Ranking Member Senator Burr for his opening remarks.
Thank you, Senator Murray, and good morning to our witnesses. Dr. Abraham, good to see you, and to our other witnesses that join us virtually. 1 year ago today, March 9th, there were 1,020 COVID cases in the United States, and 35 people had died from complications from the disease. This was still, at that time, not a threat based upon what CDC and other agencies said. Since then, 28 million people have contracted COVID-19 in this country, and more than 514,000 Americans have died from it. Globally, 116 million have contracted COVID, and 2.5 million have died from this once-in-a-century pandemic. The committee has an awesome responsibility ahead of it. We must take stock of lessons learned from response to COVID pandemic and learn together to see what worked, what didn't work, and what needs to be done to be more prepared in the future. We should be proud of the work, or proud of the important laws, programs, and policies we've worked on together in this committee to create and fund, because so much of it worked exactly as we envisioned. FDA used its emergency use authority to get vaccines and therapeutics to the Americans in record time, while maintaining the gold standard of safety and efficacy. The Assistant Secretary for Preparedness and Response coordinated with healthcare providers on the ground to ensure the sharing of critical information and supplies as quickly as possible during the response, and coordinated with NIH and BARDA to kick out countermeasure development into high gear. Using BARDA's authorities, Operation Warp Speed developed and scaled manufacturing for multiple vaccines in record life-saving time. But we should also be humble enough to know that more needs to be done to be prepared for the future. I hope now that the partisan spending bill is over, that only had 5% of its funding dedicated to public health, to the public health portion of COVID response, and 1% of their massive spending bill dedicated to COVID vaccines, we can shift our attention back to working together. As we start this thorough review process, it's important that we remember that we're still in the midst of our current response. But the tools we have today look very different than where we started over 1 year ago, largely because of the authorities that we've given to the executive branch. In May of last year, some experts were predicting that a vaccine could take years. In partnership with the private sector, we did it in 10 months. Testing is now widely available, with the FDA announcing just last week that emergency authorization of another test that delivers results at home, thanks to public-private partnership and leadership from the NIH. Our doctors and nurses have found new ways to better treat our sickest COVID patients, improving outcomes with better clinical practice guidelines, and our state and local officials have led the charge in tailoring our response to their community needs, as they should. Alongside our success, we must acknowledge our failures. At the beginning of the academic year, just 17% of our nation's schools had fully returned to in-person learning, jeopardizing the future and potential of an entire generation of Americans. Businesses are still closed, with the Restaurant Association estimating that 100,000 restaurants will not ever be back to welcome customers. And the tools we have to solve these urgent problems, a vaccine should be reaching more Americans faster. The CDC stated that we're averaging 2 million shots in arms per day. But this administration has not updated its goal to reach 100 million shots in 100 days, which was already the trajectory when the president took office in January. Instead, we should set aspirational goals, like we did with the development of the vaccine, not easily attainable ones. When we look at where we are in response today, the data shows a significant decline in COVID cases and hospitalizations. I share this with my colleagues not because we should let up on our response, because I believe we are at the greatest moment right now to learn from our progress and to learn from our failures. The time to capture the lessons we are learning is now, in real time, and not months down the road when case levels are low, attention spans are shortened, and urgency fades. I remind my colleague, in the life of BARDA as an institution, it's been on life support 3 different times because Congress lost interest in funding advanced development. To our witnesses, welcome. Each of you spent the last year in the thick of COVID-19 response, 24 hours a day, 7 days a week. Thank you for your tireless efforts. I hope we can learn from each of you today about what was most important during the days of pandemic and the strategies that were most effective at the height of cases and deaths over the holidays, and the ways your response is changing as the vaccine is made available to more and more Americans. Your input is critical as we begin to consider the next phase of the current response, and as we look to the next public health threat that we will face. It's not a matter of if, but of when. We'll need to turn to the tools and policies we're using today for yet another novel or emerging threat to our nation's health and its security. The questions I'll raise with each of you today are: what did we get right? What did we get wrong? And what parts of our response were not part of the anticipated plan of action originally? Throughout this year, the committees held many bipartisan hearings and bipartisan briefings, and we spent countless hours on the phone and in meetings with experts from around the country. This was a wise decision, despite its logistical difficulties, because it allowed us to begin to build the record necessary to move forward. This is our first hearing on COVID response as Congress, and I look forward to working with Senator Murray to make these hearings and these conversations a regular practice of the committee. I know that we're in the process of securing administration witnesses for a hearing in the near future. And I'd like to set the expectation for all of us on this committee, on both sides of the aisle, that we should expect to hear from administration officials on a regular basis, just like we did with the last administration, if not more often. They have an obligation to be open and transparent with Congress and the American people about what they're doing in real time. And I know all of my colleagues on both sides of the aisle will join us in this request. Dr. Abraham, to you and the other witnesses today, thank you for being here. Please share with us, if you can, those personal experiences, those personal decisions that you made that may have gone counter to what the federal guidelines were, but they were unique to your community, in your area, in your state, in your community health center, and why that decision was so crucial for you to pivot to something you thought would work and in fact did work. With that, Madam Chairman, I thank the chair and I yield the floor.
Thank you, Ranking Member Burr. We will now introduce today's witnesses. I'm very pleased to start by welcoming Dr. Umair Shah from my home state of Washington. Dr. Shah was appointed as Washington's Secretary of Health last year and has been on the front lines of our state's efforts to get vaccines into arms and to keep families safe. The progress we've seen is encouraging, especially as new vaccinations per day now outpace new cases, and cases are down 70% from the peak this winter. I'm grateful to Dr. Shah for the work he's done to help get us here, the work he continues to do to help us finally end this pandemic for everyone, and for taking the time to join us today to share his insight and expertise. Before his current role, Dr. Shah served for several years as the Executive Director and Local Health Authority for Harris County Public Health in Texas, the third largest county in the nation. He served as a term as President of the National Association of City and County Health Officials, and he served as an emergency medicine physician at the Houston VA. Dr. Shah received his MD from the University of Toledo Health Science Center and completed his residency at the University of Texas Health Science Center while earning his MPH there. Dr. Shah, welcome. Thank you for joining us today. Next, I will introduce Dr. Ashish Shah. Dr. Shah is the Dean of Brown University School of Public Health, and before that, he taught at the Harvard T.H. Shah School of Public Health and led the Harvard Global Health Institute. Dr. Shah is a renowned expert on pandemic preparedness, whose work has been published in over 200 research publications. He has led groundbreaking research on Ebola and been a key advisor to policymakers looking for thoughtful analysis as they work to respond to COVID-19. Dr. Shah received his MD from Harvard Medical School, completed his internal medicine training at the University of California, San Francisco, and completed his MPH and a fellowship in general medicine at Harvard. He was also elected to the National Academy of Medicine in 2013. Dr. Shah, I'm glad to have you with us today. Dr. Jerry Abraham is the Director of Kedren Vaccines at Kedren Health, a community health center in South Los Angeles, California, where he also serves as a family medicine physician. Dr. Abraham has publicly championed the importance of vaccine equity and how we achieve it, and has worked to make it a reality in his role leading vaccination efforts in underserved communities that have been hit especially hard by this pandemic. He's a graduate of the University of Southern California's Keck School of Medicine, where he also completed his family medicine training. Dr. Abraham, community health centers like yours are a lifeline to patients across the country, and one that has become all the more important during this pandemic. I look forward to your testimony about the work happening in your community and what we can learn from it. So thank you for joining us. And now I'll turn it over to Ranking Member Burr to introduce Dr. Fuchs.
Thanks, Senator Murray, for the opportunity to introduce Dr. Marianne Fuchs from Durham, North Carolina. For almost 20 years, Dr. Fuchs has served as Vice President of Patient Care and System Chief Nurse Executive for Duke University Health Systems, where she's responsible for overseeing the nursing practices and ensuring the high-quality care across the health system. Dr. Fuchs also serves as the Associate Dean of Clinical Her Bachelor of Science degree in nursing from the State University of New York at Birmingham. Dr. Fuchs is a fellow in the American Academy of Nursing, a fellow in the Wharton Fellows Program in Management for Nurse Executives, and a Robert Wood Johnson Executive Nurse Fellow. Dr. Fuchs, thank you for all the important work you're doing and what you're doing on behalf of North Carolina and the country and nurses across the country during this challenging time. I look forward to hearing your perspective from the front lines of the fight against the COVID pandemic. Thank you, Madam Chair.
Thank you. We will now move on to testimony. Dr. Shah, you may begin your remarks.
Good morning, Chairmember Murray, Senator Burr, members of the committee. Thank you for your leadership and for inviting me to testify today to share my observations on the COVID-19 response to date. Let me start by saying this pandemic is far from over, and we need to stay the course in using every tool available to end it. We're all tired of the pandemic, but we cannot forget the more than 500,000 Americans who have lost their lives to date. In our state of Washington, that means 5,000 Washingtonians whose lives have been lost. While we still have a long way to go, it is my hope we are on the right road. I also hope this pandemic is an inflection point that results in real sustained change to protect the safety of all Americans. My name is Dr. Umair Shah. I've responded to countless emergencies over the last 20 years, including hurricanes and tropical storms, infectious disease outbreaks, chemical incidents, and even global earthquakes. My family and I experienced firsthand the massive power outage in Texas just a few weeks back. I'm a public health professional and medical doctor as an emergency department physician at Houston VA Medical Center, taking care of our nation's veterans for over 20 years. In late December, I was honored to be appointed by Governor Jay Inslee as the Secretary of Health for the great state of Washington. Honored because Washington has been a leader in responding to this pandemic, and this is a testament to Governor Inslee's leadership, as well as the work of our state health agency and countless partners on the ground. While I'm new to the state role, I've been on the front lines fighting this pandemic this past year and leading the public health efforts at Harris County Public Health in Texas. And as a previous president of NEA, I recognize the absolute importance of what happens in local communities. That said, I am now a proud member of the Association of State and Territorial Health Officials, ASTHO, representing the state public health agencies across the country who serve as a key intersection between the federal government and local communities. Over this past year, we have all witnessed the loss of life, impact on countless patients and their families, and communities devastated by COVID-19. Watching this play out, I have been frustrated by seeing the strain on our public health system to ramp up epidemiology, surveillance, laboratory testing, communications, contact tracing, and now getting vaccines into arms. I'm here today, though, not to just express frustration, but to work towards solutions. Please refer to my full written testimony. Today, I will touch on two main points. Number one, we need to stay the course using public health tools to help end this pandemic. And number two, public health truly matters, and there is a cost to chronic underfunding. So with the first point about staying the course, from our response, we remain focused on three things. One, getting Americans to continue everyday precautions. Number two, distributing and administering COVID-19 vaccines. And number three, safely reopening schools and businesses. Overall, we may see the light at the end of the tunnel due to vaccines, but we must support preventive measures that have gotten us to where we are today. We cannot let our guard down, or this pandemic will make us pay yet again. We must emphasize the importance of following public health guidance, including wearing masks, watching distance, getting tested, and avoiding large gatherings. Secondly, the focus around the country is getting COVID-19 vaccine to arms of people quickly and equitably. To do this, we're balancing three legs of a three-legged stool: vaccine supply, number two, logistics and operations, and number three, vaccine demand. Currently, our biggest challenge is limited supply, but we expect this to improve, as you know. As far as operations go, we are grateful to Congress working to get resources to support our efforts on the front line and within states. As we ramp up supply and capacity, we must pay attention to demand, as vaccine hesitancy is real, whether due to mistrust or misinformation. Third, we all want our schools and businesses to reopen for in-person learning and get our economy moving ahead, but we want to do so safely. If communities continue to control the spread of COVID-19, the road ahead is better than the one we have been on. Public health, number two, truly matters, and there's a cost to chronic underfunding. Everyone, everywhere, in all communities should be able to rely on strong public health systems. This pandemic has shown the shortcomings of our current system, including for emergency response. This is due to the fact that we have not adequately invested in it. We must support a public health system ready to protect Americans from all hazards, including pandemics, natural disasters, biological, chemical, nuclear, and terrorism. This pandemic has been horrific in so many ways, yet it is a transformational event. Now is the time to make smart, strategic, and sustained funding in public health infrastructure. Making these investments, we must also address longstanding health inequities. COVID-19 did not start these, but it has made them worse. The inequitable distribution of death and disease means we have seen communities with disproportionate impacts from this pandemic. This is simply unacceptable. To reset, reform, and rebuild, federal investments must prioritize and resource equity. And now is the time for Congress to act. We're making progress against COVID-19. We can see the light at the end of the tunnel, but leaders must stay the course because there are still threats ahead, including the risk from COVID-19 variants and COVID-19 fatigue. Let me close by saying public health is the invisible offensive line of a football team, and we're not doing enough to invest in that offensive line. We keep focusing on the quarterback. We have an invisibility crisis in public health for far too long. If nothing changes, we'll get more of the same systems without the robust capacity and capabilities to respond to the next emergency. We're truly at a crossroads. Either we can act now and invest in public health, or we act later and overspend dearly to undo that which could have been prevented. On behalf of the state of Washington, thank you, Senator Murray, for your leadership, ASTHO, and my colleagues across the nation. I appreciate the opportunity to testify today. We look forward to working with all of you, all of us in public health, in building safe, healthy, and protected communities across this great nation of ours. Thank you.
Thank you, Dr. Shah. We'll turn to Dr. Shah.
So good morning, Chairwoman Murray, Ranking Member Burr, members of the committee. It is indeed an honor to be here. As we heard, we mark a grim anniversary this week, 1 year into a global pandemic that has caused unimaginable suffering and loss. But we are also seeing the beginning of the end of this pandemic. Infections and hospitalizations are down. More than 2 million vaccines are going into arms every day. And we will have enough vaccines for every American adult by the end of May. This is an extraordinary achievement of what has been a long and difficult road. But as you've heard already this morning, the pandemic is not done with us. There is important work ahead to get back to a time where Americans feel safe living their daily lives, where our economy is thriving again. So let's talk about what remains to be done. First and foremost, we need to continue to focus on equitably expanding national and global vaccine supply and distribution. We're at a time when new variants and strains pose real risks, and the longer the virus circulates, the more it will mutate. Our full efforts and attention must be focused on vaccinating as many Americans as quickly as possible. And we have to do it far more equitably, far more equitably. So far, vaccinations for people of color has lagged far behind those of white Americans. We need a renewed strategy that ensures that those at the highest risk of this pandemic are getting vaccinated quickly. And Congress should demand that we systematically collect and publicly report data on vaccinations by race, ethnicity, age, and income to ensure Americans who need vaccinations are getting them. Next, we need an aggressive global vaccination strategy. Because if the pandemic has taught us anything, it's that viruses don't respect borders. If we continue a slow global rollout of the vaccine, it is entirely possible that strains will emerge elsewhere that threaten the efficacy of our current vaccines and possibly even render them useless. We will then have to reformulate, retest, and redistribute vaccines and revaccinate our population. At current global vaccination rates, it will take 3 to 4 years to reach widespread global immunity. Now, the Biden administration has taken important steps, including rejoining WHO, and Congress has committed funds to COVAX. These are good things, but unfortunately, they are not enough. We need a strategy that isn't just about more money, it's about substantially ramping up production of these vaccines. This will require more global collaboration, and it will require US leadership. Next, closer to home, we need to build up more rapid testing. Some Americans will choose not to get vaccinated, and vaccines, as good as they are not 100% effective. That means we will continue to see some outbreaks of COVID for the foreseeable future. We need a testing and surveillance system that can help prevent outbreaks and keep us all safe. In a world of low transmission and high vaccine coverage, we need cheap, easy to administer tests that are widely available. These exist today. Now, the FDA should work through the regulatory challenges to make many more of these tests available to the American people. And Congress should continue to make investments to ensure these tests are affordable. Even with vaccinations and testing, people will get infected and some people will get very sick. And we need more investments in therapeutics, particularly outpatient therapies. We've identified several good treatments for critically ill patients, but we have very little to offer to people before they get very sick. Congress should work with NIH to continue to support development of new outpatient treatments that can render this disease far less harmful. And finally, we need a renewed set of investments in public health, as you heard from Dr. Shah. This pandemic has shown us the cost of underinvesting in our public health infrastructure, the economic and human costs, which are not borne by all of us equally. They are borne by some of us much more than others. We need a new set of investments in public health infrastructure that puts equity at the heart of its mission. Over the long run, we need to remember that we are entering an age of pandemics. Infectious diseases caused by pathogens jumping from animal to humans will become more common as a result of economic development and climate change. And globalization means an outbreak anywhere will quickly become an outbreak everywhere. And that's the world we are looking at. So to conclude, we are at a critical moment in this pandemic. We can see the time when we get our lives back, but we must do a few key things. Invest in vaccinations, testing, therapeutics, and public health infrastructure to ensure that we bring this pandemic to a close and to ensure that we prevent the next one. Thank you.
Thank you, Dr. Shah. We'll now turn to Dr. Abraham.
Madam Chair, Senator Patty Murray, Ranking Member, Senator Richard Burr, Senators, I would like to thank the committee for this opportunity to discuss this paramount issue, the COVID-19 pandemic. My name is Jerry Abraham, and I'm a family and community medicine physician, a global injury epidemiologist, and a medical quality specialist practicing in South Los Angeles. I provide care to patients at Kedren Health, a federally qualified health center and acute psychiatric hospital, serving low-income patients, diverse patient populations of South Los Angeles. First, on behalf of Kedren and our president, Dr. John Griffith, we extend the warmest thanksgiving and gratitude to each of you for inviting us to share our experience and perspective on the issue of healthcare service and public health delivery to underserved populations during this time of this COVID-19 pandemic. Before I begin, we at Kedren want to acknowledge the local leaders who make it possible for our measured success. Governor Gavin Newsom and the State of California Department of Public Health, our Los Angeles County Department Board of Supervisors, our Supervisor Holly Mitchell, our local LA County Board of Supervisors, specifically the City of Los Angeles and Mayor Eric Garcetti, our Councilor Kern Price, and of course our very own Congressional Representative Maxine Waters, who represents us here in Washington. I would also like to begin by thanking the Biden administration for their leadership in working with physicians and other providers across the country to address the COVID-19 pandemic. It has made a tremendous difference to have national leadership, transparency, and communication about the pandemic and this vaccination effort. Across this country, the pandemic has exposed deep-seated divides within our communities. Data from the CDC shows that Black and Latinx populations who contract this disease are dying at twice the rate of other populations. Nowhere is this felt more deeply than in South Los Angeles, where we work, where those living in poorer communities struggle daily with access to medical care amongst the worst pandemic in over 100 years. This population is more likely to utilize public transportation, to struggle with limited access to mental health services, to have difficulties related to language and insecurity due to the lack of immigration documentation. They usually lack medical insurance, underinsurance. Our population suffers from higher rates of hypertension and diabetes and obesity. The point is that racial and ethnic, economic, lack of equitable access to health care and public health, and a whole raft of other issues related to disparities result in health outcomes that are different. While it is easy to unmask this effect related to vaccination rates, the same forces play out throughout the entire healthcare system. But really why I'm here today is to tell you about the story of the little Kedren that could, the historically black institution from South Los Angeles that started in the 60s by 22 black psychiatrists when African-American individuals in South LA had nowhere to turn when they were in mental health crisis. That's the place that I work, and that's the place that answered the call March 2020 when we knew we had to be a part of the response of this pandemic. We became a resource, a safe haven, safe harbor, truly that light for testing right away for our county and our city. We knew that testing strategy and contact tracing would be critical in ending this epidemic. In December, when the FDA approved Pfizer and then shortly thereafter Moderna and the EUA was approved, we knew we needed vaccines, and we picked up the phone and we do what we do best every day, overcoming health disparities and addressing social determinants of health and achieving health equity. We called and we asked our Department of Public Health, where are our vaccines? And we worked lock in step with our local public health jurisdiction to make sure that we got vaccines. Our nurses had COVID, our patients had COVID, and we knew we needed to vaccinate our community now. And so we ended up getting 100 doses. Christmas Eve, we started calling. By New Year's Eve, we put 50 doses into the arms of our staff, and the next day 100, then 150, and today over 52,000 doses into the arms of people in South Los Angeles. We said, don't give us enough just for us, give us enough for our brothers and sisters to our right and left, other healthcare workers who had nowhere else to turn. And after that, we said, give us enough for all of our frail and our elderly and our vulnerable that needed a vaccine today. What we do and what we do exceptionally well is we took down every barrier that stood in the way of our patients and their vaccines. Internet, email, phone, transportation. I can't speak English. I cannot walk. I cannot see, hear, talk. None of those are reasons not to get vaccinated in this country. And we made sure we broke down every one of those barriers. What we do exceptionally well, why we're the Center for Excellence and the exemplary role models, we vaccinate a high volume of individuals as equitably as we can, and we report that data back accurately and timely back to the appropriate jurisdictions. No barrier stands in the way with our patients. What stands in our way is we need more vaccines. We need more hands to administer them. We're thankful for every volunteer who comes and helps, over 200 volunteers daily, and we need more resources, and that we're very thankful for the work of Congress and the Senate in making sure that that's achievable. This is our shot. We must end this epidemic. We must engage and educate and vaccinate our communities. We can achieve 100 million vaccines and more, as Senator Burr mentioned, and we will and we can get back to work, get back to school, loving our loved ones and doing all those wonderful things we used to do before this pandemic, loving and hugging and kissing everyone. And that's the story that we have to tell, and thank you so much for allowing us this opportunity to be here before you today. Thank you.
Thank you, Dr. Abraham. We'll turn to Dr. Fuchs.
Thank you, Chair Murray, Ranking Member Burr, and members of the committee. I'm honored to represent our many frontline staff who have worked tirelessly to care for all of our patients, including those suffering with COVID-19. Duke University Health System is comprised of a hospital and healthcare network that spans the care continuum, and we are dedicated to providing high-quality patient care, educating tomorrow's healthcare leaders, discovering new and better ways to treat disease, and partnering with our community to improve health. We appreciate the committee's leadership in addressing the current pandemic, and on behalf of Duke Health, thank you for the critical support Congress has provided over the last year, including through the CARES Act and subsequent legislation. Over the last year, COVID-19 has posed persistent challenges for the communities we serve, our patients, and our team members. And as chief nurse of our health system, I know these issues firsthand. As COVID-19 persisted, I worked with multiple teams to create new strategies to meet patient care needs, reallocated internal resources to adapt to influxes of patients, and quickly pivoted when circumstances changed. We set up new delivery models and care practices, established testing and treatment sites, and stood up vaccination sites for employees and patients. We served our community as a major transfer center for the sickest patients and provided resources to skilled nursing facilities in the form of testing, staffing, and training. We responded to the ever-changing information by regularly updating our care, holding town halls and virtual forums for our employees and the community. And like many health systems, we were the hub of the COVID-19 response in our community. This past year has offered us many lessons learned, which I hope can inform future actions of this committee. We are committed to protecting our workforce. We were impacted by a real and global shortage of N95 masks and other PPE, as well as stockpiles that contained expired PPE. Our supply chain team worked around the clock, sourcing from around the globe to ensure we had adequate and effective PPE. Our workforce must be cared for and offered respite, caring for critically ill patients, comforting families of loved ones suffering in isolation, and fearing bringing the virus home to our families has taken a significant toll on the mental well-being of our workforce. We are seeing their exhaustion compounded by pandemic-related anxieties and increased responsibilities at home. In my role as president of AONL, we continue to advocate for resources to protect the physical and mental health of the workforce. And we know through a recent national AONL study that the availability of healthcare workers is still a major issue, along with addressing burnout and building resilience. Duke Health also joins other organizations, including the AHA and AONL, in supporting the Dr. Lorna Breen Healthcare Provider Protection Act. And before the pandemic, our nursing workforce needs outpaced our supply. Thus, we continue to support increased funding to Title VIII nursing workforce development programs and support the Future Advancement of Academic Nursing Act, which would make critical investments in nursing infrastructure. COVID-19 has also served as a blunt reminder that we cannot afford to overlook our public health infrastructure and workforce. Thanks to a grant from our state, Duke Health's COVID-19 support services program has been able to assist community members requiring to isolate or quarantine. Over 30,000 people have been provided relief payments, meals, supplies, transportation, and medication delivery. We established a vaccine equitable distribution committee to better understand our data and reach marginalized populations, including those who are disproportionately impacted by the virus. We have dedicated appointments and vaccines, and we partner intentionally with community organizations. This work has improved the rate of African Americans vaccinated in our community from 8.8 to more than 15% today. The impact of the expansion of telehealth services has facilitated connection to our communities and demonstrated the efficacy in delivering care. We want to ensure that telehealth will remain accessible to more patients on the other side of this current crisis. The substantial financial impacts of COVID-19 on hospital and health systems will also have lasting effects. Systems now face difficult decisions to reduce costs. Additional support is needed, including eliminating further reductions in payments through federal programs, including Medicare and Medicaid, to maintain access to care. In closing, as the number of vaccinations increase in combination with continued infection prevention measures, we need to acknowledge pandemic fatigue, be patient with each other, and work together to continue to provide the highest quality care in the safest manner. Thank you for the opportunity to serve on the witness panel for this important conversation.
Thank you, Dr. Fuchs, and thank you to all of our witnesses today. We look forward to your responses to our questions. We will now begin a round of 5-minute questions, and I ask my colleagues, please keep track of your clock, stay within those 5 minutes. Dr. Shah, for over a year, we have been responding to the greatest public health crisis in over a century. COVID-19 has pushed our public health system to the brink and underscored a lack of desperately needed resources. That's why Democrats included robust funding for vaccines and awareness campaigns, testing, and public health workforce in the American Rescue Plan, among other critical public health priorities. In the all-hands-on-deck effort to end the pandemic, we must center our response on equity and reach every community. Populations hardest hit by COVID-19, including communities of color, tribes, and other underserved populations, must be prioritized in outreach efforts, and websites and information tools must be accessible to people with disabilities and English language learners. Dr. Shah, can you tell us what is Washington State doing to make sure things like testing and vaccines are accessible to everyone?
Thank you, Senator Murray, and thank you again to all of you for your leadership on this issue. I would say that there are a number of things that we've been doing, and it starts not just today, but starts way back in the fall. It was really around a number of dialogue and sessions where we reached 20,000 Washingtonians to also work with them and learn from them about what their prioritization thoughts were. In addition to that, we have put together, as in my written testimony, the VAC Center, which is public-private partnership, coming together to help with really efficiencies and numbers, but also a VIX, which is a combination of really dialogue sessions and feedback sessions with stakeholders for equity. I think the key message is that COVID-19 did not start these inequities. It has only made them worse. And so we have really an incredible amount of work ahead of us to make sure that we're really underscoring all the feedback from these communities and all the people that are impacted disproportionately by COVID-19, but also addressing them by giving them a voice in the work that we're doing. And I think that's critical as well.
Okay, thank you very much. And Dr. Abraham, we do have a long history of health inequities in this country, which have only been exacerbated by the pandemic, as Dr. Shah just said. It is completely unacceptable that Black people are dying from COVID-19 at 1.4 times the rate of white people, and that Native Hawaiian and Pacific Islander populations are contracting COVID-19 at over 3 times the rate of white populations. Despite this, in nearly all states, Black and Latino people have received a lower share of vaccinations compared to their share of cases, deaths, and population. We know vaccinations are an essential tool to end this pandemic, and they need to reach communities that are hurting the most. I am impressed with your health center's success in vaccinating communities of color you serve. Tell us how we can make sure vaccines and information about them are reaching communities of color.
Sure. Thank you for that question, Senator Murray. As Dr. Shah and Dr. Jha mentioned, we have to build this public health infrastructure yesterday, and we really needed those networks. And what we have really strong in South LA are networks of Black and brown physicians who knew we had to work together to race to get our patients vaccinated. So we've been in close collaboration with the physician community in South LA to figure how we can better coordinate our response. We work lock and step. This whole rollout has been a series of marriages between Kedren and our local Department of Public Health. It has been working lock and step with our state government and making sure that the supply chain reached community health centers, FQHCs, to make sure that we get clinicians and providers access to the essential medicines, because this is what we do every day. We vaccinate our patients, we care for them, and we educate them. So trust us to continue to do our job, and we will get more of America vaccinated. But what we build today really is a revolutionized healthcare delivery system. There is an opportunity in this crisis, and that really is to bring a public health infrastructure that has been lacking, and we must wed public health and the healthcare delivery system together.
Okay, thank you very much. Senator Burr, I'll turn it over to you.
Thank you, Madam Chairman. All of you have talked about inequities. Let me just put another one on the table, rural versus urban. It hadn't been mentioned. And I think you leave out a lot of America when you don't talk about rural America and how difficult it is to reach. And Dr. Abraham, it is unbelievably refreshing to hear you say, we just built our system, what we needed. Regardless of what Washington said, we built what works. And that's what's so unique about the local communities and the empowerment of those communities. Dr. Shah, as I mentioned in my opening statement, we're closely examining the first year of our response to the novel coronavirus, and we've seen things we didn't expect. One most obvious recent things, partnership between pharma companies with each other, an innovator, a discoverer, and now a big pharma company that takes on a contract manufacturing role of finish and fill. We never dreamed that these things would happen, but they're happening. Our successes are due in large part to the ability of state and local public health officials to identify and address the unique needs of their community during the pandemic. The way that Raleigh handles COVID-19 in North Carolina is not the same as Seattle, and we need to address it. Let me ask you, Dr. Shah, do you agree that state and local officials should be the leading voices for the needs of their community as we continue to respond to COVID-19?
Senator, thank you for that. And Absolutely, state and local officials have an incredible role to play, and we do need to lead because we do know our states, we do know our localities, so absolutely. That said, we also have a responsibility to make sure that our federal partners are also at the table and also leading. There are certain things that the CDC can do, that the guidance that allows for consistency across the country is also incredibly helpful. I will tell you, on the front lines, it has been so challenging this entire year of up and down, back and forth, left and right, this and that, to try to fight a pandemic. And so all the tools that we can have, there are roles of government at the federal level, at the state level, and the local level that all work together. So ultimately, we are protecting the community member. And that consistency of either policy or communications is absolutely critical to the success, not just for this pandemic, but in future emergencies.
Dr. Shah, we've spent millions over the last decade to set up a surveillance system in the United States as an early warning system to detect things like this. Hopefully, it would have seen pandemic earlier, responded to it faster. Did our surveillance system fail, and what should we do?
Yeah, so Senator, thank you for that question. And you know, a year ago in January of 2020, actually, I wrote a piece in which I said that I thought the US would have a relatively robust response to the pandemic because we had such a good surveillance system. We had great laboratories, great doctors, great nurses, great hospitals. We do, it obviously clearly did not work. I think our surveillance systems are not as robust as we need them to be. We don't do enough surveillance out in the community. You know, one of the things that we've learned, for instance, is wastewater surveillance is a very good way of finding diseases before we start detecting them in humans. We haven't really made a national effort to do that kind of surveillance. There's a whole series of things that are much more public health and not so much who comes into the doctor's office that we need to be investing in. And then the other part that really failed us was the data infrastructure. Even if you could identify cases or diseases, we could not aggregate it and look at the broader pattern in individual states or let alone across the country. You know, just yesterday, COVID tracking, which was an effort by a group of journalists packed up after a year of pulling together data and making it widely available. That's the data that we all use as a nation, was data coming from a group of journalists. We need the government to be able to pull together data across states, do surveillance, and make it available for policymakers and academics.
So, Dr. Shah,
none of that worked as well as it needed to have.
Dr. Shah, how can the private sector be better leveraged and incorporated into biosurveillance system to support federal, state, and local public health decision-making?
Yeah, well, the private sector's got the tools, right? I mean, if you think about genomic surveillance, for instance, there are some fabulous American companies that have that technology, and the U.S. government's got to partner with them. I completely agree with the premise of this and your other questions that so much of the success of this pandemic has come from the federal government and sometimes state governments partnering with the private sector. That's how we have beaten this thing. And when we think about future investments, that's the mindset we're going to have to use.
Thank you, Doctor. Thank you, witnesses.
Senator Casey.
I want to thank Chair Murray, and I want to start as well by thanking the witnesses for the focus on public health infrastructure. And I want to thank Chair Murray for her dedication to this issue over time, because we don't talk about it enough and frankly have not moved forward in a manner that would prepare us for the next pandemic. I'll start with Dr. Shah. You talked about the need to build resilience in the public health system and about the relationship between both public health infrastructure and public health preparedness. So I've got a couple of questions. Do you think it's possible, Doctor, to be as prepared as possible for a public health emergency without investing in public health infrastructure?
Well, you know, thank you, Senator, for that question. I will say that it becomes extremely difficult. It's really about building the capacity, not in the middle of the crisis or not reactively trying to throw dollars at it, but in advance of, to build that capacity so public health can respond. And so when Dr. Shah just mentioned about the surveillance systems, the data system, he's absolutely right. These are systems that in advance of COVID-19, if we had this investment in public health infrastructure would have been robust, would have been strong. Now, we can look back, that's fantastic, but we really need to be looking forward. And that's really about investing in systems in a very smart, strategic, and sustainable way.
And part of that, I guess, is at the local level. And I guess the follow-up to that is who are the people you would hire and the other investments you'd make, and what other resources would be used when we're not in the middle of a public health emergency, as you suggest, to be prepared for what's ahead of us?
Well, I think we need to be thinking, look, our Department of Health in Washington has been stood up for 400 plus days. I mean, that's remarkable. Same thing, Harris County down in Texas, same thing for 300 plus days. We're talking about a year plus of response. Public health systems are fatigued both physically and honestly, emotionally. I think the key message is that we need to be thinking about how do we make smart investments in that workforce so we support the workforce, we make sure that that workforce is both physically and emotionally and behaviorally supported, but we also think about bringing into the workforce the technology, the logistics, folks that have the cost effectiveness, who understand process flow, who have efficiencies of that. And also we in public health have to do a better job of communications. We have to do a better job of really making sure that we can engage with our communities so people recognize that we are part of the solution, not part of the problem.
Doctor, thanks very much. I want to move to Dr. Shah regarding children, and I want to start by thanking him for being such a great communicator at a time when we needed clear and science-based communication across the country. But the one issue that relates to our children that has gotten some attention, but probably not enough, that while children are less likely to become seriously ill from COVID-19 by way of comparison to adults, they still can spread the virus. And you and others have spoken about MISC, the multi-system inflammatory syndrome in children, a very serious condition. After we've prioritized the higher risk populations and are immunizing now tens of millions of people, once we get to the immunization of children and teens to reduce community transmission in cases of this MISC, and we know that all of the major drug companies are running or plan to run pediatric vaccine trials. Can you speak to the process that's underway and assess the safety and efficacy of these vaccines for children and teens as you see it right now?
Yeah, so Senator Casey, thank you. A critically important question, right? Because it will make, it's going to be very hard to reach population herd immunity if everybody under 18 is not vaccinated. And while the disease does have a much milder effect on most kids, there are high-risk children with chronic diseases for whom this could be quite substantial. And then, of course, we do ultimately want to get kids vaccinated. I think we can. And I think the question is, when are we going to have the data to feel comfortable about the safety of these vaccines in children? Now, I do believe we have trials running, Moderna, but some of the others are also for kids 12 and over. And I expect a lot of that data to be available by mid to late summer. The problem will be the younger children and looking for efficacy, looking to say, does the vaccine actually work? And when infection numbers get very, very low, you're going to need very large trials to prove that the vaccines are effective. We may need to think about this a bit differently. We may need to say we want to make sure these things are safe in children and use that as a bar. But there's a lot of work to be done. We do have to get our kids vaccinated, and I worry, especially for younger ones, it may take a while to have the data to feel comfortable doing it.
Doctor, thank you very much. Thanks, Chair Murray.
Thank you. We'll turn to Senator Cassidy.
Thank you, Madam Chairman. Dr. Shah, there was just an article in MMWR about the strong relationship between obesity, even that which people would think not being very obese, but nonetheless is obese, and its risk factor for hospitalization and death. Now, Dr. Abraham and I did our training in the same area of South Los Angeles, and my own medical practice was with the poorly insured in Louisiana. And as we know, there is more risk factors such as obesity in those who are lower socioeconomic, regardless of race. To what degree do you think we can explain this disproportionate impact upon some subpopulations relative to their associated increased risk of having obesity?
So Senator Cassidy, it's a really good question, and I think you're absolutely right that we're still really learning about the impact of obesity on this disease, but no doubt about it, based on all the data that I've seen, that obesity is a meaningful risk factor for having poor outcomes. I think if you look at the broader picture of the fact that, for instance, African Americans have died at much higher rates of this disease, or Latinos, a lot of it is much higher rates of infection, which is, I think, driven by work conditions and.
Let me ask, that is increased rates of infection, but that is, we know that there's a lot of folks who are infected and we don't know they're infected, correct?
Absolutely.
So do you have surveillance testing to establish that point, or is that intuition?
Well, we have very good data that they're certainly identified far more often as having been infected. And given that testing rates have often been lower in African American communities, you'd have to, it stands to reason that the level of infections in these communities are much higher as well.
So that's more of an intuition than actually having data on that. But nonetheless, it's good. I mean, everybody respects your intuition, but it's still an issue there. Secondly, we are looking at an outcome of prevention of infection, but it does seem as if there are surrogates for prevention of infection, specifically the development of antibody response to vaccination, and perhaps the height of the antibody response. Cannot these surrogate measures be used to measure vaccine efficacy in children? Obviously, their immune systems are robust. They typically respond to vaccines better than those who are older, and yet this vaccine produces good immunologic response in those who are older. What are your feelings about using a surrogate as a marker of immunity?
It's a great question, and Senator Cassidy, as a physician, you know that the science here is evolving but getting better. I think the key question you're asking is, how confident are we about the correlates of immunity? How confident are we that antibody response, or T cells, which we can also measure, really reflect somebody's immune status? And my sense is that we're pretty close to that point, but we haven't really nailed it down. And so I can easily imagine, especially as infection numbers get very low into the summer, if we want to measure efficacy in children or in other populations, we may need to get to using correlates of immunity as opposed to direct infections. And that seems to me to be reasonable as long as we've established that those correlates are in fact right.
And Dr. John, we'll stay with you once more. Obviously, there's been a lot of concern regarding schools not reopening. You could notice.
Oops.
Heavily flavored by teachers' unions did not, even though CDC continually said that you could safely reopen, taking normal precautions. I actually am associated, or at least my wife is, with a school that did testing, and we found that the teachers and the students who were infected typically brought the infection. In fact, they always brought the infection into the school. It did not spread within the school. So what are your feelings about the ability of the schools safely reopen? Now.
Yeah. So Senator Cassidy, I believe, and I've been pretty vocal in the last several months, that I think most schools in America can open safely as long as we put in important mitigation efforts, universal masking, reasonable ventilation, and I believe testing does add a layer of protection. I have at this point believed, given how much vaccines we have, that I think we should go ahead and vaccinate teachers and staff. It would certainly add a very important layer of protection. But there's no doubt in my mind that we can get schools open in a way that can keep kids and teachers and staff safe.
Two more things, Dr. Fuchs. Let me just say that thank you for giving a shout out to the Lorna Breen Act. That is something which I am sponsoring with Tim Kaine. And so thank you for the shout out. And we want to take care of our healthcare providers. And Dr. Abraham, I did do my training at LA County USC, and the patients you see were my patients as well. And in a sense, I feel as if we're brothers in kind of caring for the less fortunate. So thank you for all the work you do. With that, I yield back.
Thank you very much. We will turn to Senator Baldwin.
Thank you, Chair Murray, and thank you to our expert panel today. Public health experts have warned that the coronavirus continues to adapt, mutate, and change. And I'm increasingly concerned about the rise of new and potentially more harmful variants. This is why I authored the Tracking COVID-19 Variants Act. And it would provide resources necessary to dramatically scale up our country's sequencing, surveillance, and outbreak analytics capacity. Now, I was proud to see a version of my bill included as part of the Senate-passed American Rescue Plan, and I look forward to seeing the President sign that bill into law, hopefully very soon. Dr. Shah, many experts have noted that we could see another spike of new infections due to a rise of variants. What can states do to respond to these emerging variants? And how will scaling up our surveillance efforts and our ability to do genomic sequencing for coronavirus make us better prepared for the future of this pandemic and future pandemics?
Senator Baldwin, thank you for that set of questions. Let me say that the number one thing that states can do is what I said, is stay the course. That we have to make sure that those mitigation efforts for prevention, which is really the robust measures around wearing of masks and making sure that we're careful as we reopen, that we do so based on evidence and the best we can for not dialing up too quickly, because as you know, that can also be challenging when you have to dial back or if there's another surge. But the other thing in the state of Washington, and one of the things that I'm really proud from the Department of Health standpoint, is that we are in the top 5 in states when it comes to genomic sequencing, when it comes to the variants, and we have discovered variants in the state of Washington. The other piece of it is that we've actually invested in more laboratory capacity in the public health lab at the state level and working in partnership with University of Washington. So I think there is what we can do to invest in our own state public health systems from a laboratory surveillance standpoint, but also working with our partners in the academic centers. So we need to do a better job and more of genomic sequencing, because remember, as you said, viruses, this is what they do. They love to mutate. They love to change. They're trying to get the next human being to try to figure out how to infect. And so this is what variants do. But our job is to make sure those public health measures are robust and strong, while we're also searching and seeking out so we can get data to individuals, policymakers, and obviously to public health officials so we can continue to monitor what's happening.
Ideally and pragmatically, what % of positive COVID tests should receive genomic sequencing to really keep on top of or keep close track of emerging variants?
Well, this is a tough one, because across the globe, there are certain countries that are doing a better job. In Europe, for example, United Kingdom, where it's somewhere in that 5-7%, I believe, rate. We're not there. We're obviously markedly lower than that. I think it's really about continuing to make sure that we make progress on it, but we do need to be working with CDC and many of our partners like APHL, Association of Public Health Laboratories, to really learn what exactly the optimal percentage is. But it's really not about just the percentage. It's about making sure it's distributed throughout the country so we have strong surveillance systems. And then we're also looking and using those surveillance systems to really discover pockets of where things are happening across the country.
Thank you. I know my time's running out, but I did want to ask a question to Dr. Abraham. Community health centers like the one you lead plays a critical role in providing health services to underserved populations. In my home state of Wisconsin, there are nearly 20 federally qualified health centers providing really important care around the state. Now, last month, the Biden administration established a partnership with community health centers to expand their role in COVID-19 vaccinations. And in Wisconsin, the 16th Street Community Health Center in Milwaukee was named one of the participating sites. I'm curious to hear from you, are the successes that you're having at Kedren being replicated at community health centers across the country, or do you think your experience is unique, and do you think more needs to be done to help community health centers in their vital mission in serving the underserved, especially as it concerns vaccines?
Thank you so much, Senator Baldwin. And it also reminds me of the question that Senator Burr had mentioned about rural populations as well. So community health centers and FQHCs really play a critical role. They're a lifeblood, whether it's urban, underserved Los Angeles, or whether it's rural parts of this nation. You know, what we've learned is that the heroic work at Kedren actually, and the work of partners and public-private partnerships really is an example for other community health centers throughout this country, especially where there is unequal access within those communities, whether they are rural or urban, to anyone who's underserved or vulnerable, those that are differently abled, minority, or at high risk for any disease during this pandemic. So what we do is no secret. It's not a magic trick. We just need more vaccines, more hands, and more resources. And the more of those that go to the places where we receive our care, whether those are our FQHCs, whether those are our small and solo physician practices, that's how we're going to get everyone vaccinated. That's what we do every day, COVID or no COVID.
Thank you. Senator Collins.
Thank you, Chairman Murray. Dr. Shah, I would like to talk with you about the critical issue of reopening our schools. I've been very concerned about the fact that so many of our students, particularly in the more urban areas of the country, still are not back in school. Maine, I'm pleased to say, is doing a good job in this regard. Just last week, I talked to the head of Maine CDC, who made the point that children are actually safer in schools in many cases than they would be in their community or in their home doing remote learning. I have tremendous respect for the CDC, but I'm very disappointed in its latest guidance on school reopenings. You have talked about that for some people in public health, that it did not appear to be particularly well grounded in the evidence and science. Similarly, Dr. Allen from Harvard has questioned the advice on distancing, suggesting that for children, 3 feet might be adequate as long as they're wearing masks. You've talked also about the need and important role for ventilation. Could you please give us your views on schools reopening and what could be done to expedite reopenings of virtually all schools so that we don't have more and more children falling behind, additional mental health problems, social development not progressing, and all of the adverse side effects from children not being in school?
Yeah, Senator Collins, it's a really good question. It's a really important question. The effects of children not being in school over the last year have been, I think, very substantial. They have not been borne by everyone equally. I think children from poorer backgrounds have borne disproportionately the impact of this. And then let's also be honest that when kids are at home, the caretaker is often the mother, and therefore it has had very negative effects and especially very negative labor market effects on women and their ability to work. And so the societal effects here are very, very large. And I think we need to think about how do we get kids back to school safely. One of the things I've been frustrated by is we've set up what I think has been a false dichotomy. We've set up kids' education versus teacher safety. And the truth is we need both, and you need both if you're going to do this over the long run. And I believe there is a way to get kids back into school full-time now and certainly into the future that keeps teachers and staff safe and kids learning. And the principles of that, in my mind, are, and this is really based on where we are today, right now you need to have universal masking in school, and you've got to have pretty high levels of adherence, 90+%. You're not going to get 100, but you got to have most people adhering to that. Second is ventilation. I really do think that having reasonable ventilation in schools is critical, and I think most schools can get that. Third is I have argued that the testing is, I think, an important component of keeping schools safe. Look, you catch outbreaks early, you offer a level of assurance to everybody that you can do this. And last but not least is vaccinations. Given, and I said this to Senator Cassidy, given how much vaccines we now have, I believe it is important to prioritize teachers, and when I say teachers, I also mean other staff in schools. I did not mention 3 feet versus 6 feet. I did not mention deep cleaning of surfaces. I think there's a lot that's gotten us distracted. I think if we focus on these things, we can keep teachers safe, we can keep kids safe, and we can open schools. And we have the ability to do all of this now, not 6 months or a year from now. That's what we need to focus on.
I could not agree with you more, and I hope that school officials, teachers, parents, and others will follow the advice that you just gave. Thank you so much.
Senator Kane.
Thank you, Chair Murray and Ranking Member Burr, and thank you to the witnesses for this important hearing. Dr. Fuchs, I want to thank you for your testimony about the challenges, it's hard to say thank you, about the challenges that our nursing workforce is facing, mental health challenges, and you indicated in your testimony, as a result, we're starting to see more of our skilled workforce leave or planning to leave, which is also being reported in recent surveys. This kind of high turnover will have a significant impact on the future of delivering health care. I want to thank Chair Murray and others. Senator Cassidy mentioned the Breen Act, who helped put funding into the COVID bill to start to deal with mental health needs of our frontline healthcare workers and public safety professionals. But Dr. Fuchs, what would you suggest to the committee that we might want to consider going forward to make sure we provide resources so that we don't see the kind of high turnover that you are concerned about?
Thank you for that question, Senator Kane. This actually is a complex issue because indeed some of the factors for individuals may very well be different depending upon individual situations. But one I would say is that clearly providing consistent support and education and access to services, I think, is extremely important for the not just the nursing workforce, for others. So, the acts that you have sponsored, I think, will be very helpful. I think there is a direct need to really study the impacts of the pandemic on the workforce, to be able to really look at different strategies that may be helpful in addition. And I think we have to continue to support our workforce. What we're starting to see now with patients re-entering care facilities is that the public is stressed. And the public is now acting out more so in addition, and placing largely nurses and those in the direct care environments in a position to be disrespected and in more violent situations. And so I think that we're going to have to place emphasis on the support of workplace violence initiatives to be able to support our staff amongst other initiatives.
Let me ask a question, thank you for that, of Dr. Shah about long COVID and how we should be thinking about that as we're thinking about what we need to do. I had COVID in March and April nearly a year ago, and it was a mild case, thank goodness. But one of the effects of it was nerve tingling 24/7 on every nerve ending in my body, and a heating pad sensation that happens about 4 or 5 times a day, where it just feels like somebody's turned a heating pad on, heats up, then 15 minutes later it goes, then it crops up somewhere else. These are mild symptoms, don't stop me from working, and the tingling thing actually helps keep me awake in long hearings. My governor in Virginia had COVID. He, 6 months later, no sense of smell. Obviously, there's nothing wrong with my skin, and there's nothing wrong with his nose. It's a neurological issue, probably just altered the thalamus or something like that. But these are not debilitating symptoms, but many have debilitating symptoms: fatigue, heart impairment, respiratory problems, brain fog. I did get asked if I had that, and I said no, but my friend said, well, how would anyone know? But as we're thinking about sort of going forward and the way we look at the health magnitude of this crisis, there will be a day where the president will declare that the emergency is over, but there's this huge category of kind of these long COVID consequences that we still don't completely understand. So maybe for Dr. Shah, how should we be thinking about that as we are, trying to put together the right plan to take care of the nation's health needs going forward?
Yeah, Senator, it's a fabulous question. And first of all, I'm happy to hear that your symptoms are mild, but as you pointed out, there are people who struggle with substantial symptoms. I think one of the things that I found most frustrating over the last year for people who like to focus on mortality rates and essentially argued for let Americans get infected and is that we did not appreciate the effects for people, the large number of people who got infected and recovered, didn't die, thankfully, but had substantial chronic debilitating symptoms. So I would say 2 or 3 things, sir. One is, first of all, we need to really study this much, much more carefully, right? We have to apply science to it the way we do everything else. And NIH, I think, has been doing some really good work on building cohorts and really trying to figure out what are the predictors, how long do these things last? Obviously, we need to work on therapeutics to try to resolve some of these symptoms, address some of these symptoms. There's some preliminary data that actually vaccinations can potentially be helpful for long COVID. I don't want to overstate how good the science on that is, but there is some preliminary data that might be the case. I'm hoping that as more people get vaccinated, that'll show up. The last point I'll say is when our president declares a public health emergency over, we are going to find a large number of Americans with substantial disability from this virus, from this infection. And the cost of that, human and financial, is going to be long-term. And we're going to have to manage that as a country.
Thank you, Dr. Shah. Thank you, Chair Murray.
Thank you. Senator Murkowski.
Thank you, Madam Chairman. And thank you to all of our witnesses. I really appreciate this discussion about the mental health side of what we're dealing with this COVID. I think last year at this time, we were all very keenly focused on the health impact, what was happening to people who were coming down with the virus. And then shortly after that, we saw the economic crisis that came following the health. And now I think we are into this third wave of a crisis, and I think it's the mental health, behavioral health side of it. And you want to talk about long haul and those long-lasting impacts, whether it's the impacts on kids, it's the societal impact that has been referenced here today. And so as we think about our providers and what we need to do to ensure that they have the help and support, and also recognizing the stigma that attaches if you are the mental health provider that says, I need mental health help now. There was an article in the Sunday news about the doctor who took her own life after dealing with COVID and then coming back and the stress of handling it all. So I think we need to be very cognizant of what we're doing to address the behavioral and the mental health needs of not only our medical professionals, our children, but at all levels now. I was looking at a full page, it was an advertisement, but not really an advertisement. It was an informational piece that was put out by the Alaska Mental Health Trust Authority, full page in our newspaper yesterday. But they are partnering with the State Department of Health and Social Services. They're bringing together a coalition of healthcare organizations, government agencies, social service providers, and community members, and they call it Crisis Now. And it's a framework for expanding the behavioral health crisis response. They're doing it in our larger communities. The big components of it are a mobile crisis team, a 23-hour and short-term crisis stabilization centers, where those who are experiencing mental health or substance use emergency can go for safe care. So the question, and I don't know, maybe this is to Dr. Shah or to Mr. Shah, maybe to any of you. I understand that this Crisis Now framework is based off SAMHSA's National Guidelines for Behavioral Health Crisis Care model. So the question is whether or not folks are familiar with these guidelines or if there's similar models that are being implemented to address the behavioral needs that we're seeing within the hospitals, but more particularly in the emergency rooms, because it's in the emergency rooms that you get them first, and the ability to be able to respond is perhaps limited. So I throw that out as a jump ball to who would ever receive it.
Senator, this is Dr. Abraham. I work at a acute psychiatric hospital. Kedren is a federally qualified health center that has an outpatient mental health outfit as well. One of the things that if you come and visit us in South LA, you'll visibly see is there is joy, there is music, there is dancing. We're turning this story around. We're at war with COVID and we are winning, and that is part of improving people's mental health. I'm hoping that with our strategies to really combat this pandemic, we do get back to work, back to school, back to loving our loved ones, and I think that has a significant impact on the burden of mental health, both for our workforce and also the patients and the public that receive the care that we provide them. What I've noticed about the over 200 volunteers that come and show up every day from the AmeriCorps and the American Red Cross and the Salvation Army, they are happy. And there is this, we're now a part of the solution. We are solutions oriented at Kedren, and we've seen how that has directly impacted people that have been morally injured by this pandemic, those that are dealing with the realities of burnout, for healthcare providers, mental health care providers who are suffering. This is the antidote. This is the cure. This is the shot, is let's get everybody vaccinated. We've seen how positively it has impacted our community.
Thank you, Doctor.
And what this is Umair Shah in Washington. I want to also give a shout out to Dr. Zink, who is the state health official in Alaska, and she does a fantastic job.
She's our rock star, really.
She is. Yeah. She absolutely is. I'm not familiar with that program, but I think one of the biggest concerns from a patient standpoint is that across the country we've had, prior to the pandemic, there was some 1 in 10 Americans had some sort of anxiety disorder or anxiety symptoms, and during the pandemic that's increased to 4 out of 10. So we've had an increase in that, and on the provider side we've had compassion fatigue as well, where there's also been the concern that some even psychiatrists or responders have not been able to cope with their own challenges from a mental health, behavioral health standpoint as they're now addressing the person in front of them. And I will agree with Dr. Abraham, is there are moments that we need to, first of all, we need to support our healthcare and public health workforce, absolutely. But there are also moments that we need to champion. So, for example, we in the state of Washington celebrated several weeks ago our 1,000th dose. Governor Inslee recognized the 1,000th dose, which is Ruby T, a 90-year-old from Eastern Washington, who received her it was the symbolic 1,000th dose of Washingtonians who had received a vaccine. And there was a big celebration, confetti and things like that. And it brought such an incredible, a positive uplifting to our own team at the Department of Health. And I will say that now, as we're closing on our 2 millionth dose actually this week, in fact, we've just passed it yesterday, there are moments of celebration in the midst of this horrific pandemic. But we do need to not just celebrate, we also need to support. We need to put the resources in, not just for physical health, but really emotional and behavioral health. And as you know, just as well as I do, this is where providers are least likely to come forward and say, I've got a problem, I've got an issue, I've got a challenge, I am burned out, and this is why we need to really be very careful, methodical, and forthright in supporting our healthcare and public health professionals with emotional health support.
Thank you. Thank you.
Thank you. We'll turn to Senator Hassan.
Well, thank you, Chair Murray and our ranking member, Senator Burr, and thank you to all of our witnesses for your testimony today and for the optimism that you have been expressing as well. I think it's much needed. I want to start with the issue of long-term care facilities. And I want to start with a question first to Dr. Shah and then to Dr. Shah. In New Hampshire, more than 70% of COVID-19 related deaths occurred within our long-term care facilities. Despite consistent pressure from me and many of my colleagues, the previous administration failed to provide the clear and consistent guidance and resources that these facilities needed to protect their residents and their staff. Secretary Shah, moving forward, what steps should we be taking to better support long-term care facilities and ensure that they are protecting their residents against COVID-19 and other infectious diseases?
Senator, thank you for that question. I will say one thing that is absolutely critical, which is that as we are continuing to prioritize populations for vaccines across the country, we cannot forget that the absolute critical importance of vaccinating seniors, those who are older in our communities, especially in long-term care facilities. As you remember, in the state of Washington, very early on in this pandemic, we had a long-term care facility where there were real issues, and that was the first, if you will, focus across the country of what we needed to do as a system to respond to the needs within those long-term care facilities. So I think it's really threefold. First of all, we have to continue with the process of vaccinations, and we need to make sure that the staff and the people, the persons who are within those facilities are vaccinated. We have to prioritize that. Fortunately, we have been, but we need to continue to prioritize that, especially as we have turnover in either staff or people. Number two is we need to make sure that we have those resources within those facilities so they also can continue to have all the protective measures, the personal protective equipment, masks and hand sanitizers, et cetera, and they have enough room to be able to cordon off individuals who are sick or have symptoms to be able to get them out of that facility or at least away from others. And number three, which is back to that additional question that I answered previously, was around behavioral health. We also have to be really thinking about the impact on seniors, on those who are in long-term care facilities by the isolation away from families, away from others who they normally would be relying on to be able to touch and feel and be a part of a family. And that is absolutely critical for us to be doing, is to make sure those resources are also there from a behavioral health standpoint as we also continue to fight the pandemic.
Thank you. Now I want to turn to Dr. Shah, because outside of congregate care settings, home health workers face unique challenges accessing paid sick leave and personal protective equipment, and many individuals who receive home-based care are struggling to access vaccines. So Dr. Shah, what steps can we take to improve vaccine availability for workers and patients across all types of care settings, including for those who are unable to travel to centralized vaccine sites?
Yes, Senator, such an important question and a couple of components to that. I mean, first I want to talk about home health workers. These are some of our least well-paid people in our society. A lot of them are hourly in their wages. And the idea that, a lot of them have turned down the opportunity to get the vaccine, and we say, well, they're, vaccine deniers or they're being hesitant. We fail to understand that these people have lives where they can't take time off if they end up having side effects. In a way that I could, when I had my vaccine shot, I could take a day off if I needed it. Many people cannot. So I think there are some really important issues about understanding the context in which people are turning down vaccinations and finding policies, as well as really having or the organizations themselves being able to pay people to take that time off or help them get vaccinated. I think that's a really important area that has not gotten enough attention, and we've been quick to dismiss these individuals who work incredibly hard, often multiple jobs, and get paid so very little. More broadly, I think, right now, in terms of getting people vaccinated across the country, my take is, we really need an all of the above strategy. And I think the administration has largely been doing this right. They've got large sites, FEMA sites, that'll attract a lot of people and will get a lot of people through. But there are a lot of homebound individuals who can't get to these sites. And so that's why we need things like mobile clinics or mobile vans, or we need community-based organizations that know where these people are and can reach out and connect with them. So my overall thinking on this has been, we've got to let states do a lot of this, and then states have to push this out to community-based organizations who actually understand the community at large and can implement a lot of these vaccination strategies.
Well, thank you very much. And I see that I'm over time, Chair Murray, so I will submit the rest of my questions for the record. Thank you.
Thank you. Senator Marshall.
All right. Thank you, Chairwoman. I appreciate it. My first question will be for Dr. Abraham. Dr. Abraham, like you, I'm a physician, oversaw 3 county health departments. I volunteered in federally qualified health clinics. We have 21 in Kansas, very proud of them. And I'm used to dealing with finite resources, and you are too. And I just want to talk for a second. I wrote a op-ed for the Wall Street Journal published last night and just kind of talk to you about how do we save the most lives? How do we save the most lives? Are you familiar with some of the new studies coming out saying the effectiveness of one shot of the vaccines? Have you been following those stories? Well, good. I think what we're seeing is one shot of either the Moderna or the Pfizer vaccine, 75 to 90% effective after one shot. And the other big news is that 12 weeks, you can still give the second shot 12 weeks later and be just as effective and raise it. If you have a finite set of number of shots and you're trying to get to herd immunity as quickly as possible, after you get the high-risk people, get 2 shots in, let's say seniors and everybody with diabetes and heart disease, you know your clinic better than I do. If we would give you the flexibility of getting everybody 1 shot that's left, getting 1 shot now and then coming back in the next 3 months and picking up that second shot, does it make sense to you that we could impact a greater number of folks? And, just a quick example, if I gave you 200 vaccinations, and you had your choice to give 100 people 2 shots or 200 people 1 shot, which would result in the greater number of people that are effectively vaccinated? And the answer is the latter, 150 people in my latter scenario. The first scenario, maybe 90. Just what would your thoughts be, would you do with that if I could give you the flexibility to do that?
Thank you so much for that question, Senator. I would gladly take those 200 vaccines, and I will make sure they get into the arms of Americans, and that's what we have to do. We've got a race against time right now. We don't have a moment to waste, not a drop to waste of this vaccine. Whichever vaccine you are offered, whether it's Pfizer, Moderna, or now Johnson & Johnson, and I'm sure there are many in the pipeline, and we'll see what the technologies bring in terms of updated versions as we continue to combat variants. However, I too believe that we must get this vaccine out. It is, as previously stated, it is not either or, it is all. My second dose patients need their second dose, and they're lining up outside my gate. And if you get your first dose from Dr. Abraham, we'll do everything in our power to get you your second dose. But we are dealing with a rationed, limited supply of these vaccines. But I do believe achieving that herd immunity as quick as we can is critical. And so to some of the points earlier made about mobile units, getting those vaccines out to the homebound, homeless encampments, to jail populations, there is clearly a critical use for single-dose vaccines. It is all, not either or.
Absolutely, and I know that I visited a federally qualified health clinic last week in Wichita that has the mobile center, and we're out there doing it. I want to turn now and just talk a little bit about the disparity, about the lack of equality of opportunity for the vaccines. In Kansas, I'm ashamed to tell you, as of about a week ago, that 10% of white Americans already had the vaccine and 5% of African Americans or minorities were vaccinated. And this was so predictable. I could just bang my head against the wall. What happened? What did we do wrong? We knew this was going to be the case, that it would be a challenge, and I knew the places to cure the problems were federally qualified health clinics and the county health departments. Those are the ones that could get the vaccines to those people. Was it that you didn't get the vaccines, or that people didn't want to get them? I just can't imagine you didn't give everything you had out. So did our governors not make the right choices on where to distribute the vaccines? Maybe Dr. Shah, you could tell me. We know it's been a bad deal. What did we do wrong?
Well, Senator, thanks for that question. I will tell you, one of the things that we have to recognize is that we've also been moving in throughout almost every, if not all 50 states, that the vaccines have been going not just in general to the communities, but going to specific priority populations. So health workers, as you know, long-term care facilities, and seniors, and then essential workers. And so, we have to make sure that our denominator is correct, that we're looking and comparing it not just to the general population of a percentage of certain populations within our states, but really those who are eligible for the vaccine. So I think the reason I bring that comment is that this is not an excuse, it's an explanation. We need to be thinking about all of this information, but as we move into populations, you are absolutely correct. We need to continue to prioritize equity. We need to continue to be thinking throughout the system, what can we be doing? And we've been doing that for months, but I will tell you the challenge has been that these public health systems and healthcare delivery systems, whether it's county health departments, whether it's what's happening within the healthcare facilities or community health centers or pharmacies, that all are ramping up with limited supply. So as we get more vaccine, we are going to see more logistics and more operations, but then we've got to then shift into vaccine hesitancy. So this is just continuing to follow and move and evolve as the vaccine process evolves as well as the pandemic itself.
Well, my time's expired, but I think we got something wrong. And then until we identify what we got wrong, it's going to be hard to correct it. So thank you. I yield back.
Thank you. Senator Hickenlooper.
Let me get that set up. Sorry. Appreciate all of your service and your time on this issue. I mean, COVID and the distribution of the vaccines has been one of the greatest public health challenges this country has faced. And it did obviously start with a lot of bumps in the road, but I, for one, have been very impressed that the resolution of a lot of these issues, and obviously there are 50 different governors in this country, I know that too well, and I think the responses and the evolution of the effort has really been dramatically improved. Yesterday, you guys have discussed this, the new guidelines and allowing the fully vaccinated a little more freedom, but still some constraints. You know, I spent a lot of time in small business and was curious what rays of hope you see for small businesses and what kind of timeline that looks like. And I'm thinking specifically of the retail small businesses, so cafes, beauty salons, you know, places where they in many cases have less than 10 and sometimes have only 2 or 3 employees. What kind of guidelines and what kind of support do you see helping facilitate them coming out of this as quickly as possible?
Senator, I'm not sure if that question is for me or for someone else, but I can take a quick stab at it and then maybe turn it over to my colleagues. I would just say that, you know, from the standpoint of what we have been really very interested in throughout and supportive of throughout is to be able to reopen and to reopen safely. Vaccines provides us that glimpse of hope. And why does it do that? Because now you have patrons in restaurants and in bars and throughout different establishments, retail establishments, who are vaccinated, who have little chance or markedly lower chance of transmitting to the person next to them in the cafe or next to them somewhere else. So as we continue to see increases in vaccine rates, we're going to start to see decrease in transmission, and that's what vaccines really promises us. However, we have to continue to be thinking about all those mitigation efforts that, you know, Dr. Fuchs, Dr. Abraham, Dr. Shah mentioned throughout, is these public health measures cannot just go away. We have to continue to dial up while we're also thinking about very carefully what we can dial down. But unless we do that carefully, unfortunately, we can see another surge. And that's what this virus has taught me this entire year. It is a super slick virus that has broken every rule in the playbook. And if we are not super smart in response, then exactly what will happen will be another potential surge.
Senator Hickenlooper, this is Dr. Abraham. I just wanted to add to that it's critical that we get the vaccines to where people live, work, and play. And so for smaller businesses, it's impossible to close your doors. How are you going to send everyone to a vaccination site? How are you going to wait in line for hours? You may not have PTO or childcare or transportation. Those are all barriers to small businesses getting their workforce vaccinated. So it's critical that we take those mobile units, we partner with our roots in the ground, the network of our business leaders, and let's get to your business and vaccinate your staff so that they can safely continue the services they provide.
I couldn't agree more. I think that's that and being willing to work on weekends, which I see where you guys have made that evolution. The last thing I'll throw out there just as a concern, you know, years and years ago, I was a scientist. I got a master's in geology, did my master's, published a couple papers, but I can't ever remember seeing so much distrust of science. And at a time where it's so important, have you guys, and again, I won't direct this to any one of you, feel free to chime in, But how do we go about rebuilding trust in science, especially in terms of rebuilding our public health department?
Really quickly, this is Dr. Abraham, and I'll just say, we deal with this every day on the front lines. We're vaccinating over 2,500 people a day. Whether you're black or brown, white or yellow, you legitimately have every reason to have questions. It is your body, your health. What is mRNA? What is an mRNA vaccine? These are real questions, and you have every right to ask them. There are questions around health literacy. There is sometimes a lack of basic science understanding, and we must meet people where we are or where they are. And so it's critical that we take the time, we engage them, we answer their questions and educate them. And those that are medically eligible, we've seen they roll up their sleeves. And let's not confuse a lack of access for hesitancy, and let's not confuse not finding parking in South LA as I don't have time for a vaccine or I don't want a vaccine. And so those are all critical issues that we look at. Black and brown vaccination rates, you got to start teasing a lot of those things out, but take time, answer people's questions. Let's be honest with them. And those who choose to get vaccinated, we will vaccinate you.
Yeah, great. Thank you. I'm out of time. I have many more questions, but thank you so much.
Okay. Thank you. Senator Tuberville.
Thank you very much. Thanks for all of your service and what you're going through. A very tough time. What a tough time for the world and our country. I worked in education for the last 40 years. In the last 20 years, I saw a huge uptick in mental health problems with our kids. I don't know whether it's has anything to do with drugs. I'm sure it does. Lack of family, but we have a huge uptick. Now, the question I got for all of you, if anybody wants to answer this, we're getting ready, just watching our doctors and our first responders work for the last year, overworked, stress, which can cause a lot of problems. Do we have a plan to help these people that are first responders once, hopefully, we see the light at the end of the tunnel in this pandemic? Are we preparing, for what we can do for these people that have done so much for us, and then at the end of the day, it's going to hit us right between the eyes of what the problems that they're going to have?
Dr. Abraham here, I'll answer really quickly. Thank you for that question, Senator. As I say, the mantra that we have is more vaccines, more hands to administer them, and more resources and funding. When it comes to the hands, there just are not enough healthcare workers in our communities. We don't have enough nurses and doctors and every other healthcare worker that helps us deliver essential medicines and healthcare delivery and public health in this country. So part of it is we've got to build up the workforce, because myself included has not taken a day off since the day before Christmas. And that just can't keep happening. That's not sustainable, but my colleagues are racing against time in ICUs, keeping ventilators operated and keeping people from dying. The least we can do in public health and in community health centers is race against time to get this vaccine out, but it's not sustainable, and we need more healthcare infrastructure and more public health and more hands, and that means we do need to train people to do health work well.
Would anybody else like to answer that?
Yes,
Senator Tuberville.
let me just,
Go ahead.
sorry. This is
Go ahead.
So one thing I would just quickly add is, during this last year, what we saw was a pretty kind of mitigated attack on healthcare professionals. People accusing doctors and nurses of lying about how many cases of COVID there were. A real turning on these heroes who I think have saved so many lives across the country. And so one of the things that we got to do moving forward is make sure that we are not doing that going ahead, that we're not attacking frontline healthcare providers as somehow being dishonest, when I think they have been anything but that. And then the second is, as we come out of this pandemic, we really do need to, from a policy point of view, need to look at our payment systems that have made it very, very difficult for primary care practices, independent practices to survive in this pandemic. We need to find new ways of paying doctors and nurses and healthcare providers. So there's a lot of work ahead, but it certainly begins by, I think, showing people respect and understanding what healthcare workers have gone through, and not questioning their motivations.
Thank you.
Senator Tuberville, I was just going to say, first of all, I'm from Cincinnati originally, so I just wanted to give a little shout out to you from that previous jaunt with your career there. I would say that in addition to what Dr. Abraham and Dr. Shah just mentioned, I do think there is an incredible need for us to invest in that healthcare and public health workforce, both from a more of them and trained and supported, but also behavioral health wise. And your question was, are we ready for that for the future? And my answer is, I don't think so. I don't think we are. I don't think we've done enough. I don't think we have done enough. I don't think we did enough prior to this pandemic. I don't think we've done enough during this pandemic. And I don't think we're doing enough moving forward to make sure that the health and the healthcare needs and the mental health and behavioral health needs of our healthcare workers and our public health workers are addressed. We have not done enough to support it. We've got to do more. And if we do not get this right, we're going to lose more people from the healthcare system and the public health system. It's going to be a terrible loss for this country.
You know, I can't agree enough with my colleagues on the panel today. This is a big issue, and we are not prepared for the future workforce for healthcare. I recently had the opportunity to speak with both Rear Admiral Mix and Ortega about the public health workforce and the large gaps in the numbers of people and the numbers of nurses that we have prepared either in the full workforce or in the reserves. This is an extreme area, an opportunity for us moving forward. And then back to the concept of how we're caring for people within our organizations, wherever they're delivering care. We have to have flexible services that meet individual needs in a place where they can accept and be comfortable with those resources. And so that will take a very broad approach that will require additional sources of resources to be able to impact our workforce.
Thank you very much. And if I could just make one statement, Ms. Chairwoman. I told this to General Pereira last week, who is over Operation Warp Speed, been in sales or recruiting all my life. You know, I've watched how things work. We've got a lot of people who's not taking this vaccine, and we've got to have a lot more take it, even when there's more vaccines to be given. We need to come up with a marketing plan. At the end of the day, when we've got vaccines and 30, 40, 50% of the people will not take it, we've got to have a marketing plan, television and radio, to go and say, this is why you got to take it. We can't just sit back and expect people to take it. It's not going to happen. And so I think at the end of the day, probably here in a month or so, we're going to be at a point where we got to make a statement of marketing and getting this thing out to get this thing behind us. Thank you very much. Thank you for your service. Thank you, Madam Chairwoman.
Thank you.
Can I make a comment, please? We need a culturally sensitive approach to how we educate the American people. We need to meet them where they're at, as Dr. Abraham has said. We need to recognize that we have a great opportunity here. As a nurse on this panel on the front lines of our country, nurses are the most trusted professionals as rated by our public for years. And I don't believe we've taken the opportunity to really maximize the potential that we have in order to impact vaccinations. And so I look forward to partnering with many to be able to help in this work in the future.
Great. Thank you. And Senator Rosen.
Thank you, Madam Chair, and Ranking Member Burr for holding this really important hearing today. And I just want to thank all of the doctors here for your compassion during the pandemic, not just you, but all of our healthcare workforce, all of our first responders who've gone above and beyond to serve our nation. We are eternally grateful what you have done for those 500,000 families, plus families who've lost loved ones alone, and just all of it. I'm just so grateful, and I thank you on behalf of our nation. And so it is encouraging to see that 92 million Americans have been getting vaccinated, about 856,000 so far in Nevada. But greater access to the vaccine can't come soon enough. Far more needs to be done. So despite our progress, there have been challenges with appointment scheduling systems, long lines, too many individuals in underserved areas, rural communities being left out, and many Americans still waiting their first or second shot, as we know that the virus variants continue to mutate. It's critical we rapidly review what's working and make changes to ensure that no one is left behind. So Dr. Shah, from a broad systemic perspective, what do you see as the long-term changes we need to do to improve vaccine delivery, especially to our most vulnerable communities? And then I think part of this would be to address our public health infrastructure, our data systems, our creative ways to meet people where they're at, regardless of their communities. What else can we do to help you with this?
Great. So let me kind of lay out where I think what we know nationally, and then obviously folks like Dr. Shah can talk much more about the individual state level experience. When we look across the country, we see a lot of variation. Some people doing very, very well, some states doing very well, other states struggling. And if you look at what differentiates states that are doing well from those that are struggling, keeping things very simple is probably the most important. A lot of states, I think, have made this far too complicated and have made it very difficult for people to sign up, to arrive at a vaccination place. And the more difficult we make it, the harder we make it for people with fewer resources, fewer capabilities, fewer support systems to actually make it through the system. So we really have to have a ground game where we go out to people, we make this incredibly easy. So we've heard some of this from Dr. Abraham of what he's doing in LA, but it has got to be much more about getting out into the communities. And I worry a lot about the rural areas of the United States because I just feel like we have not paid enough attention to how we're going to get vaccines out there. You know, the problem here is we're trying to recreate a public health system that we have hollowed out over the last decade. And now we find ourselves saying, boy, it'd really be useful if we had a system that had good data, that had really terrific workforce that we could plug into, but we don't. And so we've got to build it for the short run because vaccines are a short-term problem. We've got to get people vaccinated quickly. But then we've got to make sure we don't pull all those investments away once people are vaccinated and say, okay, we're done, we're leaving. We've got to leave a lot of those resources and infrastructure behind because not just for future pandemics, but all the other health crises, opioids and other things that continue to plague our nation, we've got to continue to make investments in those. So I'm hoping that vaccines become really the step that we need to leave a public health infrastructure that helps us address all sorts of other public health challenges.
Senator Rosen, I just wanted to add really quickly, Dr. Abraham here, the digital divide in America, the digital fortress we've created as barriers to people and their vaccines. We really need to transform some of the digital demons that have stole grandma's shot and train them and teach them and empower them to be digital angels that actually help us use these systems. These technologies are supposed to help us, not harm us, not stand in the way between people and their vaccines. And we need to understand why we need this data, and there may be more creative ways to capture it than having a 65-plus senior in our community fighting with their computer so they can get a vaccine.
I couldn't agree more. I just have a few seconds left, so I want to talk quickly about therapeutics, research, and access. And we know that we're going to have vaccines, but people still become ill. And so quickly, I just really want to ask, what suggestions do you have to improve access for COVID-19 therapeutics for our vulnerable patients, maybe particularly in rural areas or in our areas that are underserved and folks not able to get to a tier 1 hospital, perhaps? And that's going to be our challenge now as people become vaccinated.
Well, so let me start by quickly saying I think this is an area, look, we've done a lot of things well. The scientific community has been extraordinary. The NIH has been extraordinary. But I would say that therapeutics is one area where we probably have underinvested. And I think there's a variety of issues. And we've done pretty well with inpatient therapies. We've got monoclonal antibodies, but they need outpatient infusion, which is very difficult in a lot of contexts. We actually are underusing them. And I think given the billions of dollars appropriately invested in vaccines, I would like to see a similar effort for therapeutics. You know, the virus is not going away, even when most of us have gotten vaccinated. We'd like to get to a point where if you got infected, you could take a 5 or 7 day oral course of something, which would dramatically reduce your chances of getting sick. We don't have that. We got distracted with things like hydroxychloroquine and all that stuff. We've got to let science drive this, and we've got to let the NIH really get them a lot more resources to push new therapies. We don't know which ones will work, but we've got to really try put a lot more effort into this area.
And the other thing I would just say is we have to also support our rural systems. to Dr. Jha's point, with the rural hospitals, rural healthcare providers, rural health departments that are doing just incredible amount of work, both on the vaccine side, but also on the therapeutic side. We just need to make sure we continue to support them because they have challenges that are quite different than what's happening in the frank urban areas. We need to make sure that we're also thinking about those in a very methodical way.
I would also add that different innovative models of care delivery are really important. So the work that's gone on about hospital at home programs or being able to deliver services from an enhanced home care perspective is some of the work that we have done in our health system, and we have seen the ability to treat people at home versus bringing them into the hospital. So these therapeutics, I think, have to be available to be able to be delivered in multiple places. Like, for example, we believe we can deliver remdesivir in the patient's home. We're not able to do that right now because of the restrictions around it. So we have to think innovatively about how we can deliver care differently to be able to touch the people wherever they are, and especially in our rural communities.
Thank you.
Thank you. I yield. Sorry, Madam Chair.
Thank you very much, and I will turn to Senator Burr.
Thank you, Senator Murray. I have one question and then some comments. And on the comments, any of you that want to refute what I've say, feel free to do it. Dr. Shah, some COVID-19 models have started to incorporate weather patterns into their predictors for the trajectory of pandemics. Are there other data points or sources
because it tells us something about how people are behaving. We have in the public health world, and this is a broader societal problem, not thought through how this incredible proliferation of data that is out there is getting incorporated and used for public health modeling. Of course, we need basic laboratory data and all of that, the standard stuff, but we need a new approach. And it raises a whole series of questions, Senator, because countries like China, for instance, use incredible amounts of personal generated data, but they do it in a way that I think is not consistent with our values. It's not the way we would want to do it in a democracy with privacy and security. So we need to find ways, these are policy issues, these are regulatory issues, where we can access and use these kinds of data in a way that people feel that their privacy is still being conserved. We've barely begun to scratch the surface of this issue.
Well, I'm delighted to hear you say that because I think we do have to think outside the box as we talk about, in the future, a layered surveillance system, one that leverages technology. And we've proven in medical research that you can de-identify data and it can be used, and used very successfully. A few comments. With the flu every year, we flood the zone, to use a football analogy that Coach would say. We flood the zone with vaccines and we make it as easy as possible, in large part because we've got unlimited vaccine production. We never thought about the multi-use manufacturing needs that we were going to have. And we've got to rethink that, and we've got to incorporate that in our architecture of the future. When airlines adopted a mask policy and put HEPA filters in every airplane, and people started flying with a mandatory mask and with filtration, but no social distancing, we never had an instance of super spreader off an airline from the time they restarted that new system. I'm not sure why we're so scared on schools. If we've got a mask and we've got filtration and we've got distancing, which is the third thing, and the fourth thing is we've got a population of kids that we have the data that shows they're less likely to contract. And it's just amazing to me that we have put off so long putting these kids back to school, letting mothers and fathers go back to work and to resume some normalcy in their lives. Three, the vaccine process, I agree with, I think, Dr. Shah. We've made it way too difficult. And I think, Dr. Abraham, you've simplified it where you are. I remember I was in a hospital one day that was known for heart bypass surgery. And when they explained to me what a typical day was like, and the first 2 operations, they required them to stay inpatient the night before. My question was, why? There's an added expense. And they made it clear that any missed operation the next day broke their model of how they reduce cost in healthcare but make money at the end of the day. So if you can't assure that your first 2 people wake up and show up on time for their pre-op, you've messed up the entire day of bypass surgery. Well, anytime we have an interruption in the line of people that are sticking in arms when we've got a limited number of stickers, Dr. Abraham, I think you alluded to it, we have missed an opportunity. So we've got to simplify this, as it was said. We've got to make sure that our focus is on sticking as many arms as we possibly can in a given day with the number of vaccines that we have. And the system today was not set up to do it. We have a limited number of healthcare professionals that can do it. This is not new. We identified this in the early 2000s when we started the pandemic legislation with PAPA and other things. And we identified that we needed a parallel effort to try to identify an oral delivery system, because sticking people in arms is a very difficult thing in a national and global picture. Well, thank God we've had healthcare professionals that were retired that have come back to the front lines and volunteered pro bono to come out and stick people because they're already trained, and we've got to tap into that supply even greater. Either Dr. Shah or Dr. Shah alluded to the fact that we can't get there if we've got 147 million Americans that aren't going to be vaccinated because they're under the age of 18. And I agree totally. As this infection begins to decline, the pediatric indications that are needed for historical determination to make safety and efficacy pass the test is going to be impossible. It will take years. And we really need to do that population at least down to an 8-year-old before school goes back next year. So I hope that some of the words that you go out and preach are words that accept the standard that we're going to have to use technology to close the gap on making those determinations, which is not the historical model that FDA and others have used. We're asking federal agencies, quite frankly, to do historical things they haven't done historically, in large measure because technology gives us the ability to gap that now. But let me assure all of our witnesses, government is the last one that will take advantage of it unless it's the medical community that pushes Congress to make the changes, that pushes the federal agencies to make those changes. Partnering with the private sector is absolutely essential to mapping out the way to address pandemics of the future. And we are the worst partner for the private sector, we the government, that exists in the marketplace. We've got to change that. It can no longer be the CDC is in charge of all testing, which is where we were 1 year ago on March the 9th. And not until we created RADx over at NIH with Dr. Collins' leadership over it, did they start to partner with the private sector to bring all sorts of new testing capabilities, both in office, in home, and we're going to continue to expand on that. But we've got to get outside of the historical paradigms that exist. Technology, innovation, and investment are the only way that we will improve the future. And that's in all aspects of pandemics. The heroes in this story are the individuals on the front line. Without them, we'd fail. With them, we have accomplished something that 12 months ago most people believed we couldn't do. We've developed 3 vaccines and hopefully a 4th very soon. We have immunized now millions of Americans. And I agree with the comments that were made. We can't stop with looking at America and saying, when are we going to be immunized? Until we find a way to be the driver of global immunization, then we will not feel comfortable about where we are. America needs to open up our schools. We need to open up our business. We need commerce outside of the United States. And until we find a way to immunize globally, That is not going to happen at the levels that we've got to get it to. So it's not just about how do we buy 600 million doses for the United States, which can vaccinate every American. It's how can we use American assets to leverage manufacturing capabilities both here and globally to where we manufacture cost-effective vaccines, maybe with U.S. technology, maybe with U.S. companies, and we leverage the rest of the world to do it. You'll never get them to do it if we don't display a willingness to partner between the federal government and the private sector going forward. So, Chair Murray, I thank you for this hearing. I thank our witnesses for their expertise, and I'm willing to take any criticism about my observations from any of you.
Well, thank you very much, Ranking Member Burr. I just have a couple more questions, and I want to, again, thank all of our witnesses. But Dr. Shah, if you can just answer me. In December, the U.S. ranked 43rd worldwide in sequencing of coronavirus variants, which is why I pushed to include $1.75 billion for genomic sequencing and surveillance activities at the CDC and the American Rescue Plan. But Dr. Shah, what do you see as the biggest challenges ahead in terms of identifying, tracking, and stopping these emerging variants?
Yeah, two things, Senator. First, I think your push for more sequencing was exactly right. It's what we need. I do believe, look, there's no reason why the UK has to be the global leader in sequencing. There's no reason why we have so much sequencing capacity in our country, and we just need to be doing a lot more of it. And even a lot more that we have ramped up, but even a lot more than we have right now. I remain, as I said in my opening remarks, pretty worried that we are not taking these variants seriously enough. Within a year of this disease outbreak, we have seen multiple variants that challenge our vaccines. None of them will defeat our vaccines yet. We are on a track for 3-4 more years before the world is vaccinated. And the question is, how lucky do we feel that we will not see the rise of a variant that will make all of our vaccines ineffective? So we need a surveillance program, certainly in the United States, that's far more robust. We need a surveillance program globally that's far more robust, but identifying these variants isn't enough. We've got to get the world vaccinated. As Senator Burr said, it is absolutely in our national interest, in our economic, political, health interest to get the entire world vaccinated as quickly as possible. And we are not on track to keep the American people safe that we need to in terms of getting the whole world vaccinated.
Thank you. I'm not for relying on luck myself. Dr. Abraham, the healthcare safety net has never been more important. Millions of people rely on our community health centers for primary care services. They are really a lifeline for our families, as you so know, and I was really glad we were able to secure billions in the American Rescue Plan. That investment will really help our health centers continue caring for COVID-19 patients, but we have been solely centered on COVID-19. I wanted to ask you, in addition to your work addressing COVID-19, how have you been able to manage the other primary care needs of your community throughout this pandemic?
The short answer is it has not been easy. It has required an all-hands-on-deck approach, whether you are the receptionist in our clinic or the medical assistant or every single person, including the person that wears that business hat. We've all had to race to help every patient because despite COVID, our patients still have their needs, their diabetes, their hypertension, their heart disease, and they need their refills, and they need access to diagnostics and to treatments, and we can't delay that because of this pandemic. That creates a whole nother storm. So what we do definitely is we need to have more hands on deck, more team-based healthcare delivery. We need more of all of it. So every dollar that you send from this act onto a community health center really helps us better care for our community. It gets more hands hired. It gets more resources, whether it's roofs or getting out into the community, a mobile mammogram unit. All of those things are required, but they do take resources. And with more resources, we can really do more for our communities.
Well, thank you, and I think that's one of the things we have not focused on is the other cost of this pandemic has really been all of those other healthcare needs that we have not been focused on, that have been neglected for a variety of reasons, including people not going in to get their care, but also because of the lack of access. So we need to really be aware of that and focus. I want to thank all of our witnesses today and all of our colleagues for a really thoughtful discussion. And I, again, especially want to thank Dr. Shah, Dr. Fuchs, Dr. Shah, and Dr. Abraham for your witnesses and sharing your time and knowledge with all of us, and for the work you are doing on the front lines, and for so many who are working their way through this. For any senators who wish to ask additional questions, questions for the record will be due in 10 business days, Tuesday, March 23rd at 5 p.m. This hearing record will also remain open until then for members who wish to submit additional materials for the record. This committee will next meet on Tuesday, March 15th in Dirksen 106 at 10 a.m. for a hearing on the nomination of Julie Sue to be Deputy Secretary of Labor. Committee stands adjourned.
Thanks, Patty. I'm so glad.